Good afternoon and good morning, everyone, depending on your time zone. We are so glad that you could join us today. And we're so glad to see, well, we can't actually see you, but we know there's a lot of you here and we appreciate that. My name is Julie Dudkowski and I'm one of Skyland Trail's 5 National Referral Relations representatives. I live here in the Atlanta area, not too far from the Skyland Trail campuses. Before we get started, I'd like to tell you a little bit about Skyland Trail. As many of you know, Skyland Trail is a nationally recognized mental health treatment organization. We are a nonprofit, and we specialize in treating adults and adolescents who have a primary psychiatric diagnosis through our residential and day treatment programs. And I'm excited to announce that we have resumed on-campus tours, so we would love to see some of you in person on campus. You can find additional information about our programs and services and also about our holistic evidence-based treatment model on our website at skylandtrail.org. And now I just want to go over a couple of housekeeping notes for today. Excuse me. Following the presentation today, you will receive an email from CEO with the evaluation link. If you attended the presentation in its entirety and you complete your evaluation, you will receive your CE certificate. On your CE attendee dashboard, you will receive the certificate, and you can also access slides as well as the PowerPoint and the recording from today's presentation. If you have any questions throughout the presentation, please put those in the Q&A box. Dr. Nemiroff will answer those at the end of the presentation. And now it's my great pleasure to turn it over to Dr. Ray Kotwicki. Dr. Kotwicki is Skyland Trail's Chief Medical Officer. Thank you.
Thank you, Julie. And on behalf of Skyland Trail, I want to welcome everybody to today's webinar. I have the high privilege of introducing a friend and colleague of mine, Dr. Nemiroff, who has coincidentally a CV that is over 130 pages long. So being able to figure out the most important aspects to introduce him is no small task. But Charles B. Nemiroff is a professor and chair of the Department of Psychiatry and Behavioral Sciences at the Dell School of Medicine at the University of Texas in Austin. He also directs the Institute for Early Life Adversity Research within the department as part of the Mulva Clinic for Neurosciences and co-directs the Center for Psychedelic Research and Therapy. Prior to joining Dell, Dr. Nemiroff was chair at the University of Miami Miller School of Medicine. And before that, he served as chair at Emory University School of Medicine, which is where I got to meet and work with Dr. Nemiroff. He received his medical degree and doctorate degrees in neurology from the University of North Carolina School of Medicine. Dr. Nemiroff has received a number of research and education awards, including the most prestigious Excellence in Mentoring Award from the American Psychiatric Association. He was elected to the National Academy of Medicine in 2002 and is the sitting president of the Anxiety and Depression Association of America. He was also named Alumnus of the Year from the University of North Carolina and from the UNC Medical School. Dr. Nemiroff is a member of the American Psychiatric Association Council on Research and chairs both the APA Research Colloquium for Young Investigators, as well as the APA Work Group on Biomarkers and Novel Treatments. He has published more than 1,100 research reports and reviews, and his research is currently supported by grants from the National Institutes of Health, including 6 R01s, which are currently funded to support his ongoing research initiatives. Dr. Nemiroff's contributions to Skyland Trail over the years have been quite profound. He is the inaugural chair of Skyland Trail's National Advisory Board and continues to co-chair this group of leaders in psychiatry from across the nation with me. This advisory board drives innovative program and research at Skyland Trail, including the initial inception of providing on-site physical medical care for our patients and our alumni, meaningfully using outcomes measurements to drive treatment, and evolving evidence-based treatments to meet the needs of increasingly complicated patients. Most importantly, from my perspective, from the personal side of things, Charlie is one of the most influential mentors who has helped shape me professionally. Unless I say or do something dumb for which I know he does not want to be implicated, I frequently credit Charlie with training me as a resident and a junior psychiatrist. He is a cheerleader, a model of being a physician scientist, and one of the most loyal advocates any friend could ask for. Having heard Charlie speak hundreds of times over the years, including one time earlier this week, I can assure you that we are in for a real treat today. It is my honor to introduce Dr. Charles Nemeroff at this time. Welcome, Charlie.
Thank you, Ray. That was a wonderful introduction. I wish my children were here today so they could have heard it. But all of you know me know how much I have invested in Skyland Trail academically. The research we've been able to do at Skyland Trail with you, Ray, and with Phil Harvey, so that we could demonstrate the effectiveness of the care we provide at Skyland has really been a game changer. And so I'm delighted to be with you today to talk about an area that's receiving a lot of attention in the lay media, as well as in the scientific media, and it has to do with the potential that psychedelics may have as future treatments of the disorders that we focus on. So as far as my disclosures go, you can see that all my research, as Ray mentioned, is supported by the National Institutes of Health. I've consulted to a number of companies over the years, and you see that I serve on the Scientific Advisory Board of Skyland Trail as well. So I'm going to fundamentally try to couch this presentation within the context of treatment-resistant depression, though I will have comments to make about post-traumatic stress disorder as well, alcohol use disorder, tobacco use disorder, opiate use disorder, all of which have been suggested to perhaps be a behavioral state that might lend itself to psychedelic treatment. But the mainstay of the research thus far, as you'll see, has been in the treatment of refractory depression. So what you're looking at here are the current treatment options for depression. And all of you know that there are a number of pharmacological treatments for depression, antidepressant medications, medications to augment the effects of antidepressants, such as atypical antipsychotics, and other agents like lithium, thyroid hormone, et cetera. You also know that there are evidence-based psychotherapies for the treatment of depression, and one can use those in conjunction with antidepressant medications, cognitive behavior therapy being the mainstay here. Then there's an entire group of treatments called neuromodulation, which includes 3 FDA-approved treatments, namely transcranial magnetic stimulation, vagal nerve stimulation, which requires a surgical intervention, and deep brain stimulation, which is not yet FDA approved, but experimental. And of course, the oldest treatment that we have is electroconvulsive therapy. So we have a lot of potential treatments for patients who don't respond to initial treatments. However, they're still very unsatisfied, a number of practitioners and consumers, because treatment refractory depression is a sizable problem. In the study we conducted at Emory, when we randomized patients to cognitive behavior therapy or one of 2 antidepressants, the so-called PREDICT study, these were never treated depressed patients. They were not treatment refractory, but we were only able at best to get about half the patients into remission with one of those 3 treatments. So treatment-resistant depression is a very sizable number of patients. And in the community, in treating patients with depression who have received prior treatment, even in the best randomized clinical trials, as you'll see, the remission rates are no better than about 35%, sometimes lower. That means that 65% of patients with depression are not attaining remission. And the challenge of treating those patients is depicted on this slide, which is a high suicide risk. And all of you know that there were more than 50,000 suicides in the United States last year. You know that the longer you remain depressed, the higher the relapse rate, even if you respond to a conventional FDA-approved treatment. That depressed patients who aren't responding are high utilizers of healthcare, driving up the cost of healthcare, and that many patients end up becoming depressed chronically. And we also know that there is a risk for untoward medical events in the chronically depressed population. They are more likely to be victims of heart disease, stroke, diabetes, and even certain forms of cancer. So this is a very significant problem. Now, one of the most significant factors in predicting treatment-resistant depression is a history of childhood maltreatment. And this is a very nice study published 10 years ago in the American Journal of Psychiatry by a group at the Institute of Psychiatry in London. And you can see that childhood maltreatment predicted not only a more virulent course of depression, but a poor outcome to both psychotherapy, pharmacotherapy, and the combination. So if you look at where we are with evidence-based treatment right now, this is a sort of standard algorithm for managing treatment-resistant depression. So the first thing you do is in the middle of the slide, you optimize the current treatment, either with pharmacotherapy or psychotherapy. So if patients are on 150 milligrams of a drug like venlafaxine, Effexor, you might increase it to 225 or 300 milligrams. With an SSRI like escitalopram, Lexapro, you might increase the dose from 20 milligrams to 30 milligrams. Once you've done that and the patient is still not in remission, you might go to the right side of the slide, and you might consider evidence-based psychotherapy like cognitive behavior therapy. You might go to the left and begin a treatment course of transcranial magnetic stimulation, FDA approved as well. You might go to the lower right-hand side of the slide and add a second agent that might augment the effects of their current treatment. That would be atypical antipsychotics like brexpiprazole, Rexulti, aripiprazole, Abilify, risperidone, Risperdal, etc. Of course, those agents have a certain amount of additional side effect burden that it adds to the treatment. You can go to the left side of the slide and say, current treatment's not working, we're going to try a new treatment like monoamine oxidase inhibitors or tricyclic antidepressants, the older antidepressants, or an antidepressant with a different mechanism of action like bupropion or mirtazapine. Or you could add two antidepressants together, that's the green box, and you can combine two antidepressants with different mechanisms of action. Or if everything fails, you can refer patients for electroconvulsive therapy. All of those are reasonable. The problem with all of those strategies is only a certain number of treatment-resistant depressed patients respond to them. What you're looking at here is the FDA submitted studies that ended up with aripiprazole, Abilify being approved for treatment-resistant depression. And what you see here is in the comparison, these two studies, all the patients were on antidepressants, and they either had placebo added in orange, or they had Abilify added in brown, and you're looking at the remission rates. So the addition of placebo ended up with about a 15% remission rate, with aripiprazole in both studies at most about a 26 or 27% remission rate. That's a real problem, frankly, because that means that 75% of the patients didn't get into remission. And that really shows you what the need is. Now, one of the drugs that was more recently been approved for treatment-resistant depression is esketamine. And not only is esketamine incredibly expensive, but there's been a lot of pushback after esketamine was approved by the FDA. And remarkably, this paper was published by Turner in Lancet Psychiatry, raising major concerns about why esketamine was approved relative to the weak package that was put together and submitted by the FDA. And so the unmet need for managing treatment-resistant depression is undeniable. So that leads to the question of why psychedelics? So I've tried to make the case thus far that the number one reason is the tremendous unmet need for better treatments, particularly in treatment-refractory depression. And as I've tried to summarize for you, 2/3 of depressed patients do not attain remission with the initial treatment that psychiatrists recommend to them. And remarkably, if you go to 4 consecutive treatments using an evidence-based algorithm like STAR-D, you still end up with 1/3 of patients who do not achieve remission, that are extraordinarily refractory. Now, I do want to remind myself to tell you that for post-traumatic stress disorder, things are just as grave, if not graver. We hardly ever even talk about treatment-resistant PTSD because we don't talk about remission in PTSD because it's very hard for us to help patients get to the point where they're no longer fulfill criteria for the disorder. It in of itself is fundamentally a treatment-resistant syndrome. So the question is, what is the evidence that psychedelics combined with some form of psychotherapy may be the answer for some patients with treatment-resistant PTSD or depression? And that's what we're going to talk about over the next 40 minutes or so. So let's start off with the sort of basic question, what is a psychedelic? Psychedelics are a class of compounds that profoundly alter, expand, or intensify one's state of conscious awareness and sensory perceptions. That term was actually coined by a psychiatrist, Humphrey Osmond, who put together the word mind and manifest and put it together into psychedelics, and ended up meaning mind manifesting or mind expanding. And it turned out that psychedelics have been used in a variety of civilizations dating back thousands and thousands of years. And so psychedelics have been known and have been used by a number of indigenous cultures over the course of the millennia. And they were rediscovered largely in the late 1960s. And some of them are listed here, including one of the mushrooms that produces psilocybin, one of the psychedelics that is currently being studied quite intensively. The first era of psychedelic research was actually initiated by the individuals that are shown here on this slide. And you're looking at Albert Hofmann, who was a chemist at Sandoz, which is now called Novartis, in Basel, Switzerland. And he was synthesizing various chemicals, and he discovered LSD in 1938. and he inadvertently got some LSD on his hand. And he was riding his bicycle home. And as he describes it in his memoirs, the streets started moving, the walls were breathing, his senses were altered, and he realized that he had inadvertently dosed himself with LSD. Remarkably, this drug was actually developed by the Sandoz Pharmaceutical Company. It was called Delicid, as you could see here, and it was given to investigators to potentially study. There was a sort of dark side to this. It was also investigated early on by the military as a potential part of a bioterrorism approach that they thought they might be able to use in certain military situations. But fundamentally, in the early 1950s, two faculty members at Harvard, Timothy Leary and Richard Alpert. Richard Alpert changed his name to Rama Des, and he became, they became advocates for psychedelics in the general population. And that's a picture of Jimi Hendrix at Woodstock. If you look really closely, you could see me in the upper left-hand corner. No, I'm just joking. I was at Woodstock, but I'm not in that picture. And that led to the indiscriminate dissemination of psychedelics, which had a tremendous backlash, as you all are aware, and they ended up being labeled as drugs of abuse and as Schedule I drugs, defined as having, by the FDA, no medical utility whatsoever. So what are the psychedelics? So there's psilocybin, and as you can see, there are a number of mushrooms that are depicted in this slide, all of which contain psilocybin. So it's not a single species, but a family of mushrooms that generate psilocybin. There is mescaline, which is derived from peyote, and it's another psychedelic substance. There is dimethyltryptamine and its variants, including 5-MeO dimethyltryptamine. And then there are synthetic psychedelics, including LSD, which was distributed on a blotter. And that's what those blotters looked like back in the 1960s. And then a very separate class of psychedelics, different than all of these others, is called MDMA. And MDMA, colloquially referred to as ecstasy, is really what's called an atactogen or an enactogen, and it has very different properties than the other psychedelics. It's much more characterized by feeling closer to other people, intimacy, breaking down social barriers, and much less of the visual and auditory hallucinations that one can experience with these other psychedelics. So what do psychedelics do? Well, they cause a profound alterations in several domains of consciousness. They cause visual and auditory distortions. Subjects describe changes in color, being more vivid, patterns, faces, people. Individuals describe the walls as breathing. They describe auditory distortions and enhancements. In all of the psychedelic trials I will tell you about, there is the opportunity to have eye shades on and to have chosen a playlist so that you could listen to music of your choosing. I generally recommend subjects to listen to things like Vivaldi's Four Seasons, and to avoid things like Led Zeppelin and other heavy metal, but it's pretty much up to the individual to choose their playlist. There is profound alterations in your perception of yourself, including your body. Sometimes people feel disembodied, almost as if they're looking down upon themselves, that they're outside of one's body. One can feel weightless. There is a major spiritual component to this experience, feeling a oneness or unity with the universe. Many people describe this as a transcendent experience with extreme meaning, thinking about their life and how they fit into the universe, and to their families, their colleagues, their friends. It is a profoundly emotional experience. Many people find it euphoric, extremely relaxing, with a sense of well-being, but others have described it as being very anxious. One can experience panic and even some transient feelings of dread. Certainly, there's a reduced ability during this experience to concentrate and focus or engage in any linear thought activities. Many described enhanced creativity and insight. Some people describe confusion. And then there are, depending on the psychedelic, some physiological effects. Ayahuasca is associated with nausea and vomiting. Some people experience dizziness with psychedelics. Almost everybody has an increase in their heart rate. Some people can experience an increase in the respiratory rate, as well as sweating and chills. And then, depending on the psychedelic, one can have enhanced feelings of closeness and intimacy with others, but other times, and not true with the entactogens, but feelings of paranoia or mistrust. The effect of psychedelics has a great deal to do with the set and the setting, and the effects vary greatly across individuals. And so at this point, I want to make a very clear distinction between the use of psychedelics by individuals who do not suffer from a psychiatric disorder and who are seeking to have a spiritual experience. That is quite different from the use of psychedelics in the hope that they will have a treatment of treatment-resistant depression or post-traumatic stress disorder. But very clearly, what I'm driving at here is whether one is advocating the use of psychedelics to enhance spiritual meaning on an individual basis, or whether you're thinking about this as a treatment for a severe psychiatric syndrome. What's really important is that it's done in a safe environment. I can't emphasize that enough. In order to avoid a so-called bad trip, a psychotic episode, which I'm going to talk about a little later, and for subjects to feel safe, this must occur with the set and setting carefully attended to. And it's why I have concerns about the move at certain states in the United States to allow psychedelics to be universally available to the public. And we'll talk about that more. So we could, after the 1960s and the sort of hippie freedom of expression, all things are okay, experience with psychedelics, in the 1970s, we entered the dark ages of psychedelics. One couldn't do research with them, wasn't available. The FDA would not approve any kind of studies with psychedelics. And then Rick Strassman, who is a psychiatrist at the University of New Mexico, did the very first study of dimethyltryptamine in healthy volunteers, published it in what is now known as is JAMA Psychiatry. And then a host of studies followed beginning in the late 1990s, and then moving on to the current era, where we started seeing publications appear using a more scientifically rigorous approach, randomized clinical trials of MDMA-assisted psychotherapy for PTSD, psilocybin in patients with metastatic lung cancer, for example. And then more recently, and I'll show you these data, studies on psilocybin for treatment-resistant depression. Well, for the scientists out there, you want to know, how do these drugs work? And it's very clear that the one thing these drugs have in common is that they activate a subtype of the serotonin receptor called the serotonin 5-HT2A receptor. So there's a picture of psilocybin binding to the 5-HT2A receptor, and it's very potent at this receptor, and all known psychedelics share this property. MDMA is a totally different drug. It has a different mechanism of action. As you can see, it has a number of effects, but it appears to work both on the serotonin system and the dopamine system, which is different than the other psychedelics. And we'll talk about MDMA. Remember, this entactogen is really a different class of agent. So there is data on looking at the brain to try to determine, what do psychedelics do? And so I'm going to try to describe this to you in a way that sort of makes sense to those of you who are not psychedelic aficionados. So let me say that I'm going to try to bring this experience of psychedelics down to something that all of us can relate to. You all know that we walk around in life with certain defense mechanisms. And there are things that occur to all of us in the course of everyday living that are sort of uncomfortable. Thoughts about our own mortality, thoughts about the limited mortality of people around us who we love, worries that we have about dangers that we can anticipate that are real. And so we generally push those defenses away. What psychedelics undoubtedly do is they tear away those defenses so that suddenly you're faced with them, and that can be a remarkably positive experience, as in thinking about, how many years do I have left to live? How do I want to spend my time? Am I really a great husband? Am I a great friend? How could I be a better person? But that experience can also be terrifying. So when thinking about how do psychedelics work, I think we could all agree they definitely work in the brain. So one of the things we've learned in brain imaging studies is that psychedelics work in part by changing connectivity between different networks. And what psychedelics do is they increase the crosstalk between brain areas that normally don't talk to each other. And there are some sophisticated studies that have been done. I'm just throwing this at you. I don't expect any of you to understand it. I had trouble understanding this myself, but it's an attempt to try to understand how psychedelics work in the brain. And these kind of studies will continue over time. But I want to focus the rest of my time talking about what is the data that psychedelics have a potential role in the treatment of psychiatric disorders. So I want to start off and describe to you a sort of typical paradigm of a randomized controlled trial in which psychedelics are being studied. So I took this from one of the studies. This is Robin Carhart Harris's study and I wanted you to see how the study actually worked. I want you to see literally the way this was designed. And what you see here is that patients are recruited, their telephone screened, determined do they actually have depression, do they have treatment-resistant depression. In this study, they then had a brain imaging scan, and they had a preparatory session with a therapist who described to them, here's what you might expect when you have the psychedelic experience. Then they're assessed again remotely, and then they receive a low dose in this study of psilocybin, and then they're contacted again. And in this study, they then receive a high dose, which is usually 25 or 30 milligrams of psilocybin, and then they're followed over time. They end up with follow-up, including a form of psychotherapy, which is called integration. And during the question period, I could try to talk about what that is in a little more detail. In some of the trials, there is a single dose of a psychedelic. In other trials, there are 2 doses of psychedelics. There are no studies with any more than 2 doses, and usually those are separated by a week apart or 2 weeks apart. They could be the same dose on both occasions. They could be different doses. Well, what's a therapy about? And I have a paper submitted to the American Journal of Psychiatry trying to talk about fundamentally what is psychedelic-assisted therapy. What it is not, it's not evidence-based psychotherapy. It's not, for all of you psychotherapists that are tuning in today, it is not cognitive behavior therapy. It's not trauma-focused CBT. It's not cognitive processing therapy. It's not interpersonal psychotherapy. Okay, so what is it? It's the preparatory sessions or psychoeducation. And in that, patients are advised to how best to navigate the psychedelic experience. Here's what you might expect. You might get a little history from the patients. What are the issues that you'd like to grapple with? How might you be thinking about this? And then part of the preparation is, this is what the room is going to look like. Here's what the eye shades are like. Let's put the eye shades on. I, the therapist, will be with you the entire time with another therapist. Make no mistake about it. During the psychedelic experience, there is no therapy. All you're doing is ensuring that the patient is safe and comfortable. So in talking about what the therapy is, understand the dosing sessions. The psychotherapists are there. The psilocybin effect lasts 6 to 8 hours. It's long acting. One of the unanswered questions is, would a shorter acting psychedelic experience be just as beneficial or more beneficial? What about a psychedelic that lasts 2 hours or 3 hours, for example? So this is called therapy, but obviously there's not therapy as you understand it. So, we have in our center a living room with soft lighting, a couch, comfortable chairs for the therapist to sit. And the experience is meant to be as supportive as possible, certainly not directive. And we allow the participants to interact with the therapist as little or as much as they want. But it's all about psycho support. It's about supportive psychotherapy, empathy, reassurance. I know you're feeling anxious, but that's going to pass. Take some deep breaths, listen to the music, tell me what you're experiencing. Some of the patients ask to be for the therapist to hold their hand for reassurance. That's sort of what the room looks like in our setting as well. This is a therapy room at Johns Hopkins. And this is a typical dosing session for the patient on the couch with the headphones on, with the eye shades on, with the two therapists in the room. We like to have a male and female therapist as being ideal. What we don't like is to have a single therapist in the room with the patient. The integration sessions typically begin the day after the dosing session. The therapist and the participant fundamentally have an open-ended discussion about the participant's experience, thoughts, and feelings, talk about any adverse events that occurred. But largely, this is non-judgmental, active listening with very little in the way of interpretation of the subjective experience. Patients will say, I had a conversation with my deceased mother, and here's how I felt, and one can be very reassuring with them about the experience. Obviously, the integration sessions, the need for them, the length and the number relates to how difficult a negative or positive experience the patient had. So what's common about this therapy, quote unquote, with conventional therapy is meeting with the therapist over several sessions, building a rapport, clearly important, assessment and psychoeducation, but they're very different than evidence-based psychotherapy. And certainly none of you are conducting psychotherapy with the patient wearing eye shades and listening to a headset during your therapy session. And there aren't any homework assignments as you would have with cognitive behavior therapy. Okay, now I'm going to dive into the data, and I'm going to show you what the data is. One of the first studies ever done was on psilocybin treatment for patients with metastatic cancer. Why was this study done? Because there were some early studies done with psychedelics in the 1950s to 1970s, suggested that maybe patients with terminal disease who were having a great deal of depression and anxiety might benefit from psychedelics. And so this study was conducted in individuals with metastatic cancer, 12 subjects aged 36 to 58 who had the diagnosis of anxiety associated with the medical diagnosis. So the subjects were treated with either psilocybin or a niacin, which is a vitamin that causes a facial flushing. So there was an attempt for a placebo arm spaced a few weeks apart. It was a crossover study. And you see, if you look at the anxiety scale here, that in the open circles, there's a clear improvement in anxiety 6 hours after the psilocybin, 1 day after, and 2 weeks after, a small but statistically significant effect. Remarkably, the patients were followed for 6 months, and you can see that there was about a 10-point drop in the anxiety symptom severity over the course of a 6-month period after the single dose with the psychedelic. A second study done at Johns Hopkins by Roland Griffiths, published here, was also a randomized controlled trial in patients with metastatic cancer who were depressed and anxious. There were a number of outcome measures, and 11 of them showed a clear difference between the placebo and the group difference. I want to show you the magnitude of the effect. So if you look at each of these graphs, the red line was the high dose of psilocybin, the blue line, fundamentally the low dose, which was not effective. And I want you to see a few things. So depression severity with the observer rating scale in the top left, middle top, the self-rated scale, the Beck Depression Inventory, hospital and anxiety depression scale on the right. and then the bottom is the HAM-A anxiety, the state trait anxiety, and then the profile of mood scores. You could see that the high dose of psilocybin resulted in a rapid improvement in symptoms of depression and anxiety in these cancer patients. You see that in the red line. No one would disagree with that. What about major depression? Well, Robin Carhart Harris, who's now at the University of California, San Francisco, when he was at Imperial College in London, did an open study of a low dose, 10 milligrams, and a high dose, a 25 of psilocybin, 12 patients who had failed treatment with antidepressants, 2 doses. This is the paradigm I showed you earlier as the exemplar of treatment. And what he reported was the psilocybin was generally well tolerated. The most common side effects was transient anxiety during the psychedelic experience. 3/4 of patients had transient confusion. 1/3 had headache and nausea. But look at the upper right-hand corner. You see the depression self-rating scale, the QIDS, went from about an 18. A week later, it was down to a 7. And this persisted, got down, stayed that way for 3 weeks. At 5 weeks, still better. At 3 months, about half of what it was at baseline. Conclusion, 12 patients, treatment-resistant depression, were 50% better at 3 months. That's promising, very promising. But it was an open arm study, and so very interesting, but it was open label. The patients knew what they were getting, but it was still of interest. And the patients also referred themselves to the study, so they were self-selected. Along comes the Johns Hopkins group and does a true randomized clinical trial published in JAMA Psychiatry, 27 patients randomized to a wait list or immediate treatment with psilocybin. Interesting design. 2 doses. First, a moderately high dose, 20 milligrams, and then a really high dose, 30 milligrams. So they were quite aggressive with the dosing. These patients were not on any antidepressants. So 15 patients were treated immediately, 12 had delayed treatment, and then they were crossed over to the active treatment after they were on the wait list. So 1 dropped out because of anticipatory anxiety. 1 dropped out without getting the second a dose. It was an 8-week protocol with 18 visits, and there was 8 hours of preparation over a 2-week period with 2 hours of integration. So I think the results here are pretty interesting, because what do you see here? You see, on the one hand, this remarkable reduction in the Hamilton Depression Rating Scale score at the 5-week point after the 2 treatments, from a Hamilton Depression score of 23 to about a 8 at week 5, and that persisted to week 8, whereas the patients with the delayed treatment, they showed no effect at all. That's a really big effect, really quite profound. Now, the second dose actually didn't seem to provide any additional benefit, which was something important to know. The patients weren't blinded. One of the problems with psychedelic studies is the patients know they're getting a psychedelic, the therapists know they've gotten a psychedelic, there's no way to hide, right? And how do you control for that? Because placebo treatment is so important. And then I want you to look at the upper right-hand corner of this slide to look at the side effects that the patients reported in this trial. This was included in the supplement of the paper, so it wasn't in the main body of the published paper. It's in table 8 of the supplement. I put it here because I wanted you to see that the psychedelic experience is not for the faint-hearted. So 92% of the patients felt like crying, 80% showed sadness, 77% reported emotional or physical suffering, tachycardia and 70%, shaking and trembling in the same amount, and then feelings of grief, 60%, isolation and loneliness, more than half, despair, the same amount, anxiety, more than half, isolation, fear, despair in half the patients, panic in 40% of the patients. I felt like I would lose my mind, 29% of the patients. So my point here, not for the faint-hearted, it's a rough experience. And then, of course, this report was published about a year and a half ago, which was a comparison of psilocybin with an SSRI. So the first report comparing an FDA-approved treatment. And the patients were randomized to 25 milligrams of psilocybin or 1 milligram of psilocybin, which was the non-psychedelic placebo dose, compared to treatment with escitalopram. So that's a pretty interesting paradigm. A pretty large number of subjects compared to the other trials. Everybody had to stop taking their antidepressants. And here's the result. There was no statistically significant difference between the SSRI and psilocybin. The psilocybin had a numerical advantage in terms of the reduction in the depression rating scale, but the effect was not as big as what I showed you in the previous study. So you see there was improvement favoring psilocybin if you look at the upper right-hand corner compared to favoring the SSRI, but those were not statistically significant differences. All you could say about this study was pretty short period of SSRI treatment. Many of the patients, of course, had failed SSRI treatment in the past, so it's probably that was not randomized. And the magnitude of the effect wasn't as big. Again, there were issues with self-referral. They followed these patients further in the Hopkins study, going back to that, a 12-month follow-up, and there was a substantial durable effect a year later of the depressed patients who responded to psilocybin in the follow-up study. And then this paper came out, literally 5 months ago in the New England Journal of Medicine. This is the large COMPASS trial publication, the largest study ever conducted of a psychedelic in treatment-resistant depression. They recruited 428 patients, as you can see here. They randomized 233, the others were excluded, and there were about 75 to 80 patients per group, randomized to 1, 10, or 25 milligrams of psilocybin. A low placebo dose, a mild dose, 10 milligrams, or a high dose, 25 milligrams. And here, this is one of those, a picture's worth 1,000 words. You could see the low dose had a placebo-like effect on depression severity. The mid dose had a small but not statistically significant effect. The high dose had a robust, a significant effect at day 2, at week 1, and the effect persisted with about a 12 to 10 point change, which over a 12-week period. So relatively robust effect, bigger effect than we saw in the escitalopram comparison trial. But then if you look at response and remission rates over time, you can see that at week 3, the response rate was 37%. Remember, responses of 50% improvement. Remission rate at week 3 was 29%. But then if you look at week 12, the response rate has dropped to 20%. So definitely statistically significant, not as big an effect as we would like. So now let me shift to some other important characteristics of the psychedelic debate, while so that we can include this in the question period. 25 states have considered now almost 75 bills about a reform of psychedelics. The number of bills have steadily increased. 67 of them specify psilocybin. Many have included MDMA, which we haven't talked much about yet. Most were proposing decriminalization. A few delineated medical oversight or training and or licensure for administering psychedelics. So this is the way it looks right now. So the big state in the upper left-hand corner is Oregon. Oregon has enacted a bill which will make psilocybin available to the general public. It is completely demedicalized, meaning that it will not be dispensed by physicians. There will be no requirement for physicians or psychiatrists to screen patients or be involved in the administration or follow-up to patients who receive psilocybin. One will be able to go to the mushroom store and buy psilocybin mushrooms and take them to a therapist, and you will ingest them as a patient, and then the therapist will guide you without any really almost any regulations other than the fact that you receive some kind of training online, 40 hours of training. You do not need a college degree in order to fulfill the criteria. California is considering very seriously a bill as well. And then you see these other states, including Alaska, including Hawaii, that's considering the bill. So I published this report in the American Journal of Psychiatry in December about a patient of mine who unfortunately had a extraordinarily adverse event after ingesting psilocybin. This was a 32-year-old woman with a history of mild depression that had responded to 50 milligrams of sertraline when she was in college. She also had at the time GAD. She was in her early 30s and was a professional in a firm. She was currently, sorry, not sertraline. She had been treated in the past with venlafaxine. She was not on any antidepressant at the time she ingested psilocybin. On day one with a group of friends, she had a, quote, fabulous experience. And on day two, she decided by herself, you know, that was great, I'll just do it again. So she, on 2 consecutive days, she ingested mushrooms, so it's really unclear what dose of psilocybin she actually received. She developed a severe mania characterized by psychotic symptoms, and she only required 3 to 4 hours of sleep at night. She had intrusive racing thoughts and paranoid delusions. She believed that people were observing her with hidden cameras. She took a hammer to the walls of her house and broke into the walls looking for the wires. She ended up impulsively selling her home and relocating. This was during COVID, so she was still working remotely. She became paranoid about her coworkers. She ended up getting hospitalized at a well-known academic facility where she was diagnosed with schizophrenia. She was marinated in antipsychotic drugs. She didn't respond to any of them. This psychotic manic period that lasted 3 months was followed by an absolutely severe depression, characterized by absolute anhedonia, decreased concentration, insomnia, decreased appetite, feelings of worthlessness, and suicidal ideation. By the time she came to me she had been treated with all of these medications, as well as a whole host of other holistic treatments. She had spent $475,000 on her psychiatric care, and she fundamentally, if I had to characterize her in any way, I say she was emblematic of the defect state. That is, she had no feeling whatsoever. She told me she had a dog she raised from a puppy, and if the dog was run over by a bus, that first time I saw her, she said, I would have no feeling about it. She could experience no joy. She couldn't experience anything. And to make a long story short, Steve Siegel, the chair at USC, and I treated her together, and she eventually responded to pramipexole treatment, which is a D2, D3 dopamine agonist. We could talk about that. And she's doing really well. So let me try to tell you a little bit more about other data that's available, so that then I can answer some of your questions. So this is a paper that came out recently in Biological Psychiatry on LSD. And fundamentally, it was the treatment of patients with life-threatening illness. So this was a 2-site study, double-blind placebo-controlled study with either oral LSD. It should be 200 micrograms, which is a pretty hefty dose. So normally, the usual dose of LSD is 100 micrograms. This is 200 micrograms, not milligrams, or placebo. This was a randomized crossover design, and let me show you the results. You could see that because it was a crossover, you could just see the placebo dose effect, and you're looking at the anxiety ratings at the top, and then you're looking at the depression ratings at the bottom, and you could see very clearly that there was a year-long benefit of this treatment with LSD in these patients with largely with cancer compared to the matched controls, both in anxiety and depression. This is a study that came out in alcohol use disorder, a really wonderful study that came out of NYU, which looked at treatment refractory alcoholic patients and looking at the reduction induced by psilocybin of the number of heavy drinking days in a group of alcoholic patients. So this is a remarkable study because it was a 32-week double-blind period that this succeeded the dosing of psilocybin. It also was notable in that it compared psilocybin with Benadryl, with diphenhydramine. I just want to show you the data and look at the percent heavy drinking days, as you can see here, and the drinks per day. So these patients were by and large not completely abstinent, but you can certainly see a very clear reduction in alcohol use in this alcohol use disorder population after the 2 doses of psilocybin are shown by the arrows in the graph. Well, what about post-traumatic stress disorder? So as I mentioned to you, this has been led by the MAPS group. Rick Doblin leads the MAPS group. This is the first study that was done. It's pretty amazing to me that it was published this long ago, now 11 years ago. The idea was to combine MDMA, this entactogen, with psychotherapy in patients with post-traumatic stress disorder. Small study, 20 patients, 12 received MDMA, 8 received placebo. There were 2 drug sessions and 11 non-drug psychotherapy sessions using what many of you know as the MAPS protocol. And you see, looking at the traditional measure of PTSD symptom severity, the CAPS, and then another one on the right, you see this very dramatic effect of MDMA compared to the control, which was diphenhydramine, Benadryl. A second study in 2018 looking at fundamentally military veterans, firefighters, and police officers. And you can see again, they're looking at now 30, 75, or 125 milligrams of MDMA. And you can see, looking at the caps, this very clear beneficial effect of the higher doses, the 75 and the 125 compared to the low doses. That's in PTSD, again, looking at the caps. And then finally, this remarkable paper appeared in Nature Medicine. It's one of the most highest ranking journals in our field. And you can see that compared to placebo with MAPS therapy, MDMA assisted therapy has a very clear beneficial effect in symptom severity. And you can see the effect over time. And on the left-hand portion of the slide, you see this reduction in symptom severity with PTSD. So let me finish with a few concluding slides. We don't really understand how psychedelics work on the brain to alleviate mental health conditions, for whom and when these treatments should be administered, and how they can be best delivered and optimized to maximize beneficial effects. We have a lot of questions we need to ask. How do they work? Are they better for certain individuals with certain conditions? And if so, what are the predictors of treatment response in patients with PTSD or depression? What about microdosing? Is it possible that doses that are not psychedelic are possibly effective? And there are ongoing studies to address that question. And in doses that aren't psychedelic, do they have therapeutic efficacy? There are reports like this where individuals developing a, quote, non-hallucinogenic psychedelic, using, in this case, a mouse model. So this group thinks they can actually predict psychedelics effects in humans by using a mouse model. And then if it doesn't screen positive in the mouse model, then they can do clinical studies to see if there's therapeutic benefit. That would obviously be a game changer. So what are we doing here at the University of Texas? Well, you know, I thought since Ray had unbridled enthusiasm talking about Skyland Trail and how proud we are of what Skyland Trail does, I thought I'd take a minute and tell you what we're doing at the Dell Medical School in our Center for Psychedelic Therapy. We're really interested in trying to determine what the brain imaging effects of psychedelics are, and maybe even more importantly, can baseline measures of brain imaging predict psychedelic treatment response so we could match patients with the best treatment. We're also looking at electroencephalography. We have a pilot study we're doing combining psilocybin with transcranial magnetic stimulation to see if we can get even more efficacy. And so we have a number of strengths, like the third largest computing system in the world. We're very experienced in clinical trials. We have a very high density of veterans. And so we have a lot of advantages here. And we have a number of Austinites that are extremely excited about the center and launching studies that could be helpful. So we want to recruit large representative samples for our studies, including veterans. My own interest in individuals who are victims of child abuse and neglect, I think, is a ripe population because they are, by and large, treatment refractory. And we will incorporate a number of measures of therapeutic change, not just standard depression and anxiety, but more measures that relate to quality of life, as well as biological measures of disease state. So we're going to also look at trying to design studies where we combine psychedelics with evidence-based therapy, with cognitive behavior therapy, with cognitive processing therapy, with trauma-focused CBT, as well as I mentioned, combining it with TMS or perhaps other types of neuromodulation. We're really focused on trying to predict who is this good for and who is it not good for. And so in addition to TMS, we have another novel form of neuromodulation called focused ultrasound, and we might well do studies to marry psychedelics with focused ultrasound as an enhanced treatment. So we believe that psychedelic-assisted therapy combined acts on the brain to loosen up neural circuits that cause fundamentally an increase in plasticity that allows the brain to be more receptive to evidence-based treatments. And we believe from a scientific point of view that this is where the potential is to improved outcomes, and that's certainly our hope. So we're about to launch the phase 3 trial in treatment-resistant depression. I've got 300 people that have sent emails wanting to be part of this study. So recruiting for this study is not going to be difficult. And then we will also be recruiting 100 individuals in our psilocybin rTMS trial, which will launch probably in about 6 months. We're waiting for final FDA approval. And that's it. So delighted to be with you. I'm going to turn it over to Ray. I see there are 23 questions in the Q&A, Ray, and 20 comments in the chat. So you'll let me
thank
know
you,
if you
Dr.
want me to
Nemeroff.
look at
I've
the
been
questions.
monitoring the questions, and
Okay, you'll
while
take
we're not
over.
going to have time to get to all of them, I have lumped them into some pretty obvious themes. And the first theme is that we really thank you for your expertise and all the data that you brought. The consensus is that there's a real paucity of looking at potentially contradictory, confrontational issues like psychedelics, like firearm dangers and other things, and how important it is not to be afraid of topics like this, but to study them with the same scientific rigor that you presented today. So that was by far the predominant theme in some of the comments.
Yeah, Ray, I really do want to opine about that. So first, you know me well, and you know that for me, the only thing that matters is data. And so I'm agnostic on whether you're studying moonbeams or whether you're standing on your head, or whether exercise is an important component of treating depression, or any number of medications, neuromodulatory devices, and there's a lot going on in development, new treatments. Psychedelics has caught the imagination of a number of individuals in social media, in the lay public, and part of this is because of the dramatic need for novel treatments. Again, we need to distinguish between psychedelics in the treatment of severe psychiatric conditions and psychedelics as a mechanism for individuals without any psychiatric disorder to enhance their spiritual experience. I'm not speaking about that today. That is not the topic of our conversation. The topic of our conversation is, can these treatments possibly help people who are suffering with intractable depression, PTSD, end-of-life issues, cancer, for example. I saw a patient with cardiac amyloidosis who is not eligible for heart transplant and who is facing the end of life. And the question is, are psychedelics the kind of approach that might be helpful to ease suffering? Treatment-resistant alcoholism, not to mention opiate use disorder, which killed, 140,000 Americans this year. So I'm all about the data. Psychedelics are here, and as in Oregon, there are people that are going to be taking them. So the technology, whether we like it or not, is going to be here. It's our job to apply the greatest scientific rigor to be able to inform the mental health community, both consumers and providers, as to what role might they play, where will they fit in, what are the dangers. As an example, Ray, if somebody came to me who had, say, bipolar depression and had a family history riddled with bipolar disorder, would I want to recommend psychedelics for them at this time? No, I would be worried that psychedelics might precipitate a psychotic manic episode, as in the patient I had, or somebody who wanted to have a spiritual experience that didn't have a psychiatric disorder, but their family was riddled with schizophrenia. I would worry that if you had the genetic risk for schizophrenia, a psychedelic might push you over the edge. And so I just think we need to be really sacrosanct and cautious with these powerful medications. Like the ketamine clinics that have sprung up all over the United States, many practitioners have done this because they generate a lot of income. And most of those clinics are not run by psychiatrists. Many do not have mental health practitioners. And I get it, but it's not good practice. And so I think we're going to have the same experience in Oregon with psilocybin. Because let me make a few points about that. The concentration of psilocybin in different mushrooms differs. So you're going to go to the mushroom store where some expert is going to sell you psilocybin mushrooms, and you're going to ask that expert, well, how much do I take? And they're going to say, well, cut off, the top, the cap, and then measure 5 grams of mushroom, or cut off the stem. Well, you're all going to have a scale to measure 5 grams of your mushrooms, and then how do you know what the concentration of psilocybin is? And what if you end up taking 50 milligrams instead of 25 milligrams? What's going to happen? So I'm very concerned that it was totally demedicalized. So, Ray, this is like ChatGPT. It's like artificial intelligence. It's like the technology has gotten ahead of its skis, and this is going to be available. That's very different than the MAPS approach or the Compass Pathways approach to work with the FDA to do trials in a scientific way that will inform about what place these medications may have for the treatment of these disorders.
And Charlie, I think your points about evidence-based treatments is really important, not only in novel therapeutics, but in some of the traditional things too, which leads me to a question that a lot of people were asking related to the first part of your talk today, which was the idea of treatment-resistant depression in the first place. If you have bad being bad diagnoses, you get bad out, which are bad clinical results. Can you speak a little bit to the possibility or your assumption of how many people who are diagnosed with treatment-resistant depression really are misdiagnosed and they have something else like a personality disorder maybe, or substance misuse, and they're just, kind of misclassified as somebody who has TRD, for whom something like psilocybin wouldn't be an option?
Well, Ray, thank you for bringing that up. So, as you know, this is sort of the bread and butter of my own clinical practice, and we have a program for patients with treatment-resistant depression. So I'll break it down in the following ways. So when I evaluate patients for treatment-resistant depression, the very first question I ask is the one you raised, which is, what's the diagnosis? And my job to start with is to make sure that none of the patients, that the patient in front of me, number one, doesn't have a medical disorder associated with depression. That means thyroid disease, autoimmune thyroiditis, and our definition of thyroid disease and the endocrinologist definition of thyroid disease are different. So if you have a TSH above 3.5, in my mind, you're hypothyroid, and you need to be treated with thyroid hormone to normalize your thyroid function, because you're not going to respond to any treatment if your thyroid isn't optimal. If you're a man and you have low testosterone levels, you will not respond to an antidepressant. And frankly, unless I treat your testosterone deficiency, you won't respond. And half of the time when you get treated with testosterone, your depression resolves by itself without any additional treatment. And then there are all the rarer causes of treatment-resistant depression. All that has to be eliminated. Then there are the psychiatric diagnoses. So I can't tell you how many of the patients I've seen reveal to me for the first time the history of childhood maltreatment. The fact that they have comorbid PTSD that's not being addressed whatsoever. That the fact they have occult alcohol use disorder. In fact, I saw a patient in Atlanta by Zoom yesterday, after I flew back home, who said to me, you know, Dr. Nemiroff, I'm drinking a fifth of vodka a day. Oh, well, go figure, you know, his depression's not better. How about that? So, and then, of course, there are the other diagnoses, OCD, panic disorder, opiate use disorder. All of those things need to be ruled out. If you don't get a urine drug screen, you're not going to really know about substance use disorder. And then, of course, personality disorder. And then the documenting the past treatment. You know, patient says they've been on 8 antidepressants. Well, yeah, they were on, you know, venlafaxine 75 milligrams for 2 days and didn't like it, so they dropped off of it. So in the 4 years I've been in Austin, there are only 2 patients I've sent for ketamine. All the others have responded to treatment. TMS, combinations of various medications, et cetera. Nothing's more important than the diagnosis, Ray. You said it right. If you don't have the right diagnosis, your treatment's not going to work.
Yeah. And along those lines, Charlie, there were a ton of questions from the participants today related to the utility of even considering psychedelic referral treatment in patients who have a history or are contemporarily having misuse of some other substance. So if somebody, you know, historically has used psilocybin recreationally and they're trying to get a referral to do psilocybin for TRD, is that necessarily a contraindication? Or for that matter, anybody who has a substance misuse problem, is this something to avoid in patients like that?
So remarkably not, and I'll tell you why. Because during the Nixon administration, these substances got labeled as drugs of abuse because all of these long-haired hippies were taking them at Woodstock and at other, you know, rock festivals. These are not traditional drugs of abuse. You can't, nobody could take a psychedelic every day, right? You couldn't function. And there's evidence that they can be effective in the treatment of tobacco use disorder. I didn't show you that data, but there is data on smoking cessation. There's clearly data on alcohol use disorder. There are trials going on in opiate use disorder as well. And let's face it, opiate use disorder is an emergency. So I don't think it's a contraindication at all. I think we got to stop thinking about these drugs as drugs of abuse, because there is no physical dependence on psychedelics. Traditional drugs of abuse, heroin, other opiates, even benzodiazepines, cause physical dependence. There is no physical dependence here.
Thank you. That's
Ray,
really
I have about 4 minutes of time left.
Perfect.
Well,
One
I
last
actually have to see a
question.
patient, so
Actually do clinical work.
we
One
do.
last question then, Dr. Nemeroff, because we want to take advantage of your unbridled enthusiasm for as long as we can before we say goodbye. Is there any way currently to predict based on the biomolecular makeup of different psychedelics, which patient is going to respond to which compound? And lots of questions about using brain imaging or genetic tests or other things that are available. Is the technology there at this point?
Well, the short answer is absolutely not. So what we know the most about is that, MDMA would appear to be the magnitude of the effect in PTSD is larger than the magnitude of effect in any other psychedelic study. So there's something special about MDMA and PTSD. After that is psilocybin in these other areas. There will be a psilocybin PTSD study without a doubt, and we'll see whether there's a comparison. In terms of biomarkers, there's absolutely nada.
Thank you very much. And with that, we have to say goodbye to you, Dr. Nemeroff, for today. Thank you on behalf of Skyland Trail, but really most importantly, thank you for all the patients that you have helped and that you will help in your career. We are so indebted and grateful to you. So thank you for everything you do.
Thanks, Ray.
Thank
Thanks,
you.
Julie.
Thank you, Dr.
See you
Nemeroff. We are
soon.
so appreciative of your knowledge and willingness to share that with us. We received so many wonderful comments through the chat and Q&A feature. So thank you so much.
My pleasure. Thank you all.
I wanted to take a quick moment just to thank everybody who took time out of their busy days to join us today. And I wanted to remind you about the evaluation and recordings. Later today, you will receive an email from CEGO, and that's going to have the evaluation for you to complete. If you attended the entire presentation and you complete that evaluation, then you will get that on your attendee dashboard through CEGO. We will be sending the slides, they will be sending the slides, the recording, and your CE certificate. So I hope that clarifies things for everyone, but if you still have questions, you can reach out to support@ce-go.com. And I wanted to also just let you know about a couple of events that we have coming up. We hope you'll be able to join us for our next webinar, which is actually next week on March 15th. It is entitled Ask the Expert, CBT for Mature Adults. And in this webinar, our Skyland Trail multidisciplinary team will be sharing about how our special programming and how we support older adults and midlife adults. So we hope you'll be able to join us for that. And as I mentioned, we're very excited to be hosting tours again. And we do have an adolescent campus tour coming up on April 14th, which is a Friday, and that'll be from 1 to 2. Again, our website is skylandtrail.org. You can find additional information about all of these events, all of our programs and services, and all of the treatment outcomes evidence-based research we do as well. So thank you so much for joining us, and we look forward to hopefully seeing you again soon, and have a wonderful weekend.